Stephen Query here from PEM POCUS UK, and this is our second session on the use of POCUS for the child with an undifferentiated upper limb injury. So this is the guideline we utilise in our institution, effectively working through all manners of upper limb injuries and how you might interrogate them using POCUS. So this would be the typical child that we meet who looks scared and maybe in pain, holding their arm. We again approach in our normal pediatric way, saying that the ultrasound machine isn't scary, it won't hurt them, asking them do they want to be covered in some slime, and we would typically use a high frequency probe when we're doing these scans. So the first place we would begin would be the elbow, the olecranon fossa in the transverse plane as shown here using the high frequency probe as shown. So we're looking from posterior through to anterior, and what we're seeing here are the triceps muscles and the beneath the subcutaneous tissues, and then we have this posterior fat which sits within this region predictably, but what we don't see within this olecranon fossa is typically any fluid in that region. We don't see any hypoechoic or anechoic fluid in the normal scenario. Here's another example of a normal, whereby we, again, on the still image, we only see very, very minimal trace amounts, if any, of anechoic fluid there. That's the normal physiological amount. And the idea when we're looking for a traumatic joint effusion following an elbow injury is that the anechoic material would effectively rise up in this region and fill the fossa above the level of the condyles. So here are some examples. We can see on the left, as you look at it, we see a normal appearance, and there is very minimal material within this fossa beneath the bright echogenic fat, which again is always there. And then on the affected side, we can see that this space has been filled up by, in this case, mixed echo texture material, which initially would be dark for fresh blood, but then could become much brighter over time. From there, we would then rotate 90 degrees, and we have an image that looks like this, whereby we see the proximal and then distal end of the triceps muscle being inserted, and we see the posterior fat or posterior fat pad at the bottom, and again only a trace amount, if any, of anechoic fluid. So in scenarios of a traumatic effusion, what we see is something much more recognizable to PEM and EM doctors. I'll talk about the x-ray first of all. So here we see the example of a lateral elbow x-ray, which everyone will be familiar with. Normally this posterior fat within the capsule of the elbow is hidden behind the bone on an x-ray, but when any bleeding occurs, this is pushed into an unusual different position, giving, as we see there, a shadow on your lateral elbow x-ray suggestive of a positive posterior fat pad sign. It's the same on ultrasound, whereby this anechoic material suggestive of the joint effusion, raises up that fat pad and subsequently raises up the triceps muscle. So that makes it really obvious for us to see. Here are some examples, cine loops, whereby we see the normal on this side, and on the abnormal side we can clearly see the hypoechoic joint effusion leading to the posterior fat becoming raised, and also the muscle becoming less straight and more elevated. So that's what you'd be looking out for in those two views. Beware of anisotropy, because again, if you're interrogating soft tissues and muscle fibers, the echoes can interact with the tissues and make them appear slightly darker compared to slightly lighter based on the angle of incination. So it's very important to fan through that space systematically in order to achieve the overall picture. So having interrogated the olecranon fossa in the transverse and longitudinal planes, we've ruled out any traumatic joint effusion, which effectively excludes any intracapsular elbow injury, so any bony injury from the supracondylar region to around about the radial head. And thereafter, the history will be the thing that would guide us as to what we decide to do next. We may scan to the distal radius or up to the humerus. And a large proportion of those injuries presenting, particularly in young children, would be represented by pulled elbow or nursemaid's elbow, and we have found POCUS highly reliable for this condition, and again, a bit of a game changer surprisingly for that. We all recall the mechanism of this problem, which stems from a longitudinal traction force applied to the arm, leading to a partial subluxation of the radial head from beneath the annular ligament. So this is how we would conduct the scan for pulled elbow, using the high frequency probe again in the radiocapitellar line as shown, and the anatomy we're looking at here consists of the radius, and we often in our age group don't see the fully ossified radial head, we just see part of the radial neck, and above this we see the supinator muscle, which has one of its insertions as the annular ligament. So the annular ligament would be the region just above that's less distinct than you might think on ultrasound, and we also see the more proximal distal humerus, and in this case capitellum. So the really important bit to focus upon for when scanning for pulled elbow is this supinator muscle here, the hypoechoic fibers of that supinator muscle. So when we have a pulled elbow, this supinator muscle has a very interesting appearance in that it extends much more proximally than expected into the joint space as shown here, and this produces a sign known as the hook sign, which is obviously as a result of this hooked appearance of the supinator muscle, and as a result we also see this much more exaggerated synovial fringe. So the way I describe this is that if you think the radial head has partially subluxed and moved, in this case more proximally, even perhaps at an angle rather than in terms of overall real distance, because we know any measurements along the radiocapitellar line for pulled elbow haven't been reliable either on X-ray or in any other studies. But as a result of this partial movement, what we see is that the overlying synovium flops down into this joint space, almost like removing the tent pole from a tent, causing the thing above it, the tent, and in this case the synovium, to fall in the space, giving this much more exaggerated synovial fringe with a very characteristic appearance. So if we're comparing the two side by side, hopefully everyone would recognize that it's the right elbow that has that positive hook sign compared to the unaffected side on the left. On the unaffected side, it's really important to train your eyes to look at the muscle fibers and see that they taper up to a point and stop very, very pointedly, but in the hook sign they come over, as I say, into the joint space much more in pulled elbow than you would expect. So I think what's really important when you're trying to examine these images is to really train your eyes on the fibers of the supinator muscle, which we can see on the unaffected side on the left, again taper up to a point, but the muscle fibers on the affected side again run over, consistent with this hypoechoic appearance. They run into the joint space, giving this obvious appearance, and hopefully the highlighted blue there makes it much easier for people to understand and follow. So again, this was a fantastic example that we just had recently, whereby we see the affected side, positive hook sign, exaggerated synovial fringe, compared to the unaffected side, where that muscle tapers up to a very, very thin point and does not have a positive hook sign. Hopefully that's clear to everybody. So what we were able to achieve, which was something I was keen to do for some time, which was to undertake a reduction of a pulled elbow under direct visualization using POCUS at the same time. So with the help of one of my colleagues, Dr. Kemp, we did that in our department. So I'll just let this play through a few times. But again, let's look initially at the pre-reduction, where we see the fibers of the supinator muscle have extended further over than expected. Then as the reduction begins to take place, we see the retraction of the supinator muscle backwards. In this case, it was the hyperpronation method that was used. So again, supinator muscle fibers beginning to retract, as we can see, following the blue arrow. And then in the final clip, we can see we are left with a normal, effectively annular ligament looking appearance, with the muscle fibers stopping much shorter. So hopefully that's really clear for everybody. And yeah, I think that was a world first, that visualization. So we're going to be publishing that in a journal very soon. So we undertook our own single center case series for this, which was a retrospective review of all patients presenting with elbow injury. We excluded those with a major trauma mechanism or those who had deformity, and out of 110 patients, we'd managed to scan 37 of them based on just a convenient sample of when those who had undergone sufficient training were available. And in essence, in 29 out of 37, there was the typical history. All had the positive signs suggestive of pulled elbow and POCUS, and all correctly diagnosed with pulled elbow. In 8 cases, the history was atypical, and for 3 of those, there were positive POCUS signs and a final diagnosis of pulled elbow. So reduction improved their pain and the problem. But in 5 cases, there was an atypical history with negative signs on POCUS, and in fact, other diagnoses were made, i.e., traumatic joint effusion leading to diagnosis of a fracture with an X-ray or something else. So we found this really interesting. But there were some other findings from this review that were most interesting, I think, in that out of 32 who did have pulled elbow, 16 of them had underwent X-rays, which were of course not helpful or necessary. And of 16 of those who had X-rays, 10 of them were also scanned as part of their journey, obviously after, and found to have positive signs on POCUS for pulled elbow, thereby again completely highlighting that could have been avoided if POCUS had have just been used first. But then the most interesting of all was that within our review, we had 2 patients for whom POCUS wasn't available at the time, and they underwent manipulation for suspected pulled elbow when in fact a fracture was the cause of their problem all along. So really quite hard-hitting numbers just for that small review, making a big case for the use of POCUS for suspected pulled elbow. So now I just have some cases to illustrate the different applications of ultrasound, touching on some of the things we've covered. So this was a 3-year-old girl who at nursery was reaching for her coat peg and leant on her right side, having immediate pain. The team who reviewed her felt that there was some tenderness at the distal radius. It was obviously a sort of a push type injury. When the X-rays returned, they did not appear to show any bony injury. So, as you may imagine, we scanned her, and on the affected side, we could clearly see very different appearances to the unaffected, with a positive hook sign, positive synovial fringe, therefore diagnosis of pulled elbow. So that was a push type mechanism rather than a pull. I think a push or a pull can, in some cases, potentially dislodge that radial head from underneath its annular ligament position. I've found a handful of pushes that have led to that as well, so that's quite an interesting one. Next case was a 3-year-old who had a fall onto an outstretched hand at nursery, was very upset and assessed with an X-ray. I've obviously zoomed in, giving a bit of a clue, but I couldn't at first glance be totally convinced of a bony injury. However, when we did POCUS them, we could see at the distal radius here that there is a cortical deficit suggestive of a fracture. So again, one of the examples we have of using POCUS throughout the upper limb. Our guideline goes into it in more detail, but there won't be time to show all of the scanning of the parts of the upper limb, but effectively you're just interrogating the region where you feel an injury could be present based on pain or based on some suggestive x-ray features. And I think in this case we can see quite nicely that the fracture shows up on ultrasound. This was a just over 2.5-year-old boy who'd fallen getting off a bouncy castle, landing onto the left arm. Arm was held in a partial flexion position. So we interrogated in the olecranon fossa in the long plane. And again, we can see on the affected side that we've got a positive joint effusion, suggesting that there was a fracture to me. Again, similar view in transverse. We can see on the affected side, we've definitely got a positive joint effusion filling up that olecranon fossa. And I'm sure that's something that nobody would miss who looked with a probe, even if they were beginners. And on the distal humerus view, this is sort of just slightly more, in this case, medial to the view we would do for looking at the olecranon fossa. I'm just kind of interrogating around trying to look for the bone, and I think we can probably make out just this subtle cortical deficit here, suggestive of a fracture, which I thought was quite nice to see on POCUS. And again, this corresponded quite nicely with what we see on X-ray. We can see the posterior fat pad here on the X-ray, and we can probably appreciate some separation of the trabeculae here, suggestive of that subtle fracture. So remember, we're not saying that ultrasound precludes X-rays. It's an extension of our clinical examination used in order to ensure that we order the correct X-ray, or that we direct, our resources and investigations to where we need them. This was an interesting 8-month-old boy who was laid on his front, and he began to vomit, and his older brother lifted him up from the left arm, pulling him up. One of my consultant colleagues felt reassured and convinced that this was a pulled elbow and attempted manipulation, but this was not successful. There was no click audible, and the child did not return to normal. So we're going to have a look to see if there's a positive hook sign here. So again, remember, we're looking for the hypoechoic muscle fibers here. And that's a nice view at the end there. I just want everyone to hopefully appreciate that we're looking here for the hypoechoic muscle. And we can probably see that it's much more tapered up to a point, isn't it? Rather than coming over into that joint space there and there. The synovial fringe doesn't look too pointed and exaggerated. So all in all, I was absolutely not convinced of pulled elbow here. And we did the view at the olecranon fossa, and again, not particularly positive looking. I appreciate there's a small amount of hypoechoic material here, but it's not the absolute classical appearances. Things unfortunately may not be completely binary if you do have an injury, which I'm sure you're going to know what we're going to get onto for this child, which was that I scanned the rest of his humerus, and unfortunately we can see that there is a fracture of the humerus. This was at the lab level above the supracondylar region, sort of just above really, so I guess that's the explanation for why there was perhaps a small joint effusion present, but certainly not pulled elbow, and certainly not one who should have been manipulated or continued to be manipulated. We had a look in transverse, so this is a slightly different view. We're looking at the bone as a circular hyperechoic line, which should be nice and smooth throughout, and we can see here halfway through there's that obvious cortical deficit. So when we're looking for bones in transverse, we're just scanning down. The convention is to scan in 3 different planes, so the typically lateral, dorsal, so effectively anterior, posterior and laterally, depending on which terminology you're going to use, to capture a kind of circumferential view of the bony surface. And again, as someone who does this every day, it's really binary, it's quite easy to do, and is very, very helpful, I think. So this was this young boy's fracture, as we saw. which was unfortunate, obviously, that he'd been treated as a potential pulled elbow. So by using POCUS, we can take a lot of the thinking out of this. We can quite we can quite simply direct any x-rays to where they may need to be, and we can keep patients safe by doing so without any attempted manipulations. Again, just a few cases to finish off. This was an older child who had fallen onto her arm, and we can see in this case there's again the suggestion at the start there of at least a sort of moderate joint effusion, whereby this posterior fat seems to fill up more of the olecranon fossa. We then had the view in the radiocapitellar line. I wasn't looking for pulled elbow. I was hunting around for any occult fracture, which I'm sure you'll all be able to recognise here, was at the level of the sort of radial neck, which was quite a nice injury to pick up again. You can also see some fresh, probably hematoma mixed in there with where the supinator muscle sits, giving it an unusual appearance. This was an older girl who just looked very pale and not great after having fallen off a sledge. Again, I wanted to understand what I needed to x-ray and how to treat her. So using the ultrasound probe, I scanned initially her elbow, as I always do, as I stated, but also just at the more proximal humerus, and we see this very obvious fracture at the humeral neck region, allowing me to get the right x-rays and get her sorted out pretty quickly. This was an interesting case where an older boy had reached for a sandwich and had effectively a trivial movement of his arm, but immediate pain soon after. And he presented into our department for the orthopedic team to review him, and the orthopedic team were quite upset as to why he was coming under their care, given that there was nothing on his x-rays that they could see. Possibly a suggestion, I think, when you look now, of a raised anterior fat pad, but certainly nothing else. But when he arrived in the department, he looked very unwell. He looked pale. He effectively looked like an older child does who might be becoming septic, with a sort of SIRS response. And I saw his elbow and it was rather large, so I thought the best thing to do was to POCUS him. And in the olecranon fossa, I found something very unusual in both transverse and long planes. Here we can see the same sort of thing that we would get for a traumatic effusion, but we can obviously see this horrible septated kind of organizing collection, suggestive of a septic elbow, which is what he had. So not all effusions are equal, remember, but again, POCUS is excellent for having a look at them. This was an older child who fell off her skateboard at a play park, and we would always be present in our department when any manipulations are being undertaken, either using fentanyl and Entonox or using ketamine. So I'm always there anyway, keeping an eye on the patient. And in this case, we utilize POCUS, or I utilize POCUS just to guide my manipulation. So we can see here initially at the distal radius, we've got a good 35-40 degrees of angulation, and following that we can see quite nicely that we've straightened that up to probably 1 degree, if that. And it was nice to be able to do, because we've all been involved with manipulations where we've felt they've gone very well, and unfortunately afterwards the position is not much better than it was when we started. So we don't have fluoroscopic control C-arms the way they do in some parts of the world for manipulations, but we can do it very easily without any radiation using POCUS. And this was the child 4 weeks down the line, doing brilliantly without operative intervention. And again, here's another one I done. This was the first ever one I did. I think these pictures were taken from my mobile phone when I did them. And again, we can see 30-40 degrees of angulation straightened up to a really nice position that would, in this age group, avoid operative intervention. Final case, I think, or one of, this was a girl who presented to my trauma clinic following a fall on the outstretched arm, and had had 3 sets of x-rays within 48 hours, all of which not really revealing any obvious clavicle injury, although the girl presented as though she would be clinically a clavicle. I thought I'd take a look over where I felt she was tender, using POCUS, and this is what I saw. Just a really obvious medial third clavicle injury, which really helped me because I was suspicious that something was going on. And looking back at the initial x-ray, I think looking at the medial third can be tricky sometimes because of the overlapping ribs. I think if you look really, really closely, you can perhaps possibly appreciate it looking back, but it's much easier on POCUS, and it means we're not repeating x-rays and subjecting the patient to further radiation unnecessarily. This was a 4-year-old girl who, I can't recall the mechanism of injury, but the report on the x-ray had suggested that there was a Salter-Harris 2 at the base of the intermediate phalanx. Certainly can't see anything on the AP, or I can't, and probably relatively tricky on the lateral or oblique, and this was an injury actually that was missed. So we had another look using a really cool technique called water bath sonography, which is where you immerse the child's hand or extremity in water, just in any container filled with water, and the high frequency probe or any probe does not need to be touching the patient's skin. It can be 2, 3, 4, 5, 10 centimeters away from where the area being interrogated is, and as a result of the transfer medium of the echoes through the water, nicely you get these excellent sort of almost high resolution pictures. So if anyone would like to undertake water bath sonography, it's really helpful when you need to look for occult fractures or very fine subtle changes in the cortex, or in fact looking for soft tissue foreign bodies. And I've used that a few times. The beauty of using the water bath is that you don't need to touch the patient at all. So you could, if there's a very damaged, crushed digit, for example, this works really well, and the patient seemed to enjoy it quite a lot. And in this case, I think we're just looking at this subtle angulation here, suggestive of the fracture. So in summary, we're looking at different cases. Hopefully what we've described today has been made a case for the role of POCUS in each of those injuries or scenarios, because I feel that in all it had added something that conventional x-rays didn't, or prevented diagnoses that we were otherwise going to miss, and the patient was going to be subjected to more harm. I would like to end on this slide, which I always do, which I always summarize to mean that your patients will like you more if you integrate POCUS into their care. If anyone has any questions, please just feel free to put a comment in below the video, or just to email us directly. This is the QR code to feedback for anybody who's participating in PEM POCUS UK, just to provide, it's just 1 or 2 questions to let us know what kind of content going forward you would like for us to include, a mixture of cases or literature or such like. So I hope everybody has enjoyed this video, and we'll see you next time for PEM POCUS UK.